Good morning, everyone. Today we are going to tackle one of the most common and most challenging presentations we see in the emergency department, the patient with acute transient vestibular symptoms. As many as two-thirds of acutely dizzy patients who walk through our doors report intermittent symptoms only. By the time they reach us, the nystagmus we are looking for has already disappeared. This creates a real diagnostic dilemma. We are left with recall bias, a very broad differential diagnosis, and a constant worry of missing a vertebrobasilar TIA or early stroke. The stakes are high. There are more than 4 million emergency department visits every year in United States alone for vertigo, dizziness and imbalance, generating over $10 billion in costs. And we know that the early MRI diffusion weighted imaging can miss up to 50% of small brainstem strokes. In this talk, based on recent comprehensive review by Tarnutzer, Lima Neto, and Diego Keski, published in Brain Sciences, we walk through the practical evidence based approach under following points. How structured history taking using time and trigger, the titrate framework, immediately narrows the differential. Why the single most important question is the symptoms, are the symptoms still ongoing or have they already resolved? When hints plus is appropriate and critically when it is not. Why the standing algorithm is usually better choice for transiently dizzy patient. How to distinguish benign paroxysmal positional vertigo from central positional vertigo and vestibular migraine on positional testing. And finally, how to avoid the two diagnoses we cannot afford to miss, the vertebrobasilar DIA and its great mimic, the vestibular migraine. By the end of these slides, you should have a clear stepwise diagnostic algorithm you can apply the next time a patient says, Doctor, I was dizzy this morning, but I am fine now. So let's begin. A guide to patients with acute transient vestibular syndrome, ATVS, in the emergency department. Choosing the right bedside test when hints plus applies and when standing is the better option, and how to build a diagnostic algorithm for transiently dizzy patient. Why transient vestibular symptoms are hard to diagnose. As many as two-thirds of the acutely dizzy patients presenting to the emergency department report intermittent symptoms only. By the time they reach the emergency department, the sign the physician needs most, the nystagmus, has already disappeared. Around two-thirds of acutely dizzy emergency department patients report only intermittent symptoms. 4 billion and above annual US emergency department visits occur for vertigo, dizziness, or imbalance. Up to 50% of false negative rate of early DWI MRI in small brainstem strokes has been documented as per this publication, and the costs are huge, more than US 10 billion US dollars estimated US cost of dizziness related emergency department care. The key challenges are transient nature of the symptoms, recall bias once the episode has resolved, and the clinical examination occurring outside the episode itself. So, the two patterns of the transient acute vestibular syndrome, the transient vestibular syndrome or the TVS, are ATVS, acute transient vestibular syndrome, which is a single episode of less than 24 hours, may represent the first presentation of a recurrent disorder like vestibular migraine or a one-off event like vertebrobasilar TIA, alcoholic intoxication. Episodic vestibular syndrome is again recurrent episodes, each lasting less than 24 hours, includes BPPV, vestibular migraine, Meniere's disease, vestibular paroxysmia, and cardiac arrhythmias. Why the distinction matters? At first presentation, the differential is very broad. Vestibular migraine requires 5 or more episodes to confirm the diagnosis as per the Barony Society criteria. So a single early episode can only ever be provisional diagnosis. Recurrent transient vestibular symptoms, patients may over proportionally consume the ED resources, that is the repeated imaging hyperacute stroke pathways, despite benign underlying cause like vestibular migraine. Always ask for the previous similar episodes and history of otherwise common migraine. So the structured history taking, timing and triggers, that is the titrate approach, distinguishes the spontaneous transient vestibular syndrome from the triggered vestibular symptoms together with a central oblique peripheral non-vestibular framework narrows the differential before any bedside test is chosen. The timing is very important of the duration of the episode. The peripheral episodes spontaneous lasting seconds, minutes to hours. The spontaneous and triggered. The spontaneous are cardiac arrhythmias, vestibular paroxysmia, and epileptic vertigo. They last for seconds. For minutes, the spontaneous episodes could be panic attacks, a dissociative illness, hypoglycemia, cardiac arrhythmia, vertebrobasilar TIA, and vestibular migraine. The minutes to hours is alcoholic or drug intoxication, particularly the diphenyl hydrogen sodium intoxication, Meniere's disease, and episodic ataxia, especially the newly emerging episodic ataxia spinocerebellar 27B. The triggered positional syndromes lasting seconds is BPPV, central positional vertigo. Vestibular migraine lasts for seconds. It could be a positional syndrome. And orthostatic hypotension, postural orthostatic tachycardia syndrome, and carotid sinus hypersensitivity. This is adopted from the table 1 of the publication we are discussing. Are these symptoms still ongoing or have they resolved? This is the pivotal question, the single question that determines which bedside algorithm is valid. Applying the wrong one, especially the hints plus in a patient without nystagmus, lowers the specificity of detecting central causes and drives unnecessary stroke unit referrals. So, ongoing symptoms with nystagmus, hints plus is validated. The resolved or the positional symptoms use the standing, not the hints plus protocol. So, hints plus only for ongoing symptoms with nystagmus. What does it test? Head impulse test, nystagmus pattern, test of skew, and new onset unilateral hearing loss. It is validated only when symptoms are of acute onset and still ongoing at the bedside. Spontaneous or gaze evoked nystagmus is present. The sensitivity exceeds 95% when applied by at least moderately trained examiners. A common pitfall is applying hints plus to a dizzy patient without nystagmus risks a false central pattern. Bilaterally normal head impulse test, no skew, no gaze evoked nystagmus, no hearing loss, leading to unnecessary imaging and stroke unit referral. In one acute TBS cohort, hints plus could not even be applied to 73% of the patients because the symptoms had already ceased. So the bedside algorithm 2, the standing, the versatile option for resolved or the positional TBS, 4 sequential steps, spontaneous nystagmus, present or absent and its pattern, the type of nystagmus and positional testing, that is the Dix-Hallpike and supine rule test, direction changing or associated central finding, and assessing the gait ability to stand or walk unassisted. Use it when symptoms have already resolved by the time of examination. Symptoms are positional or triggered. No spontaneous or gaze evoked nystagmus is visible. Hints plus would be uninterpretable here in these cases. So the complementary risk scores, the Sudbury vertigo risk score, a troublesome, often difficult to apply, and try score can be layered into the standing to further stratify the stroke risk in patients with resolved or positional transitional vertigo. Unlike the hints plus, both are derived in cohorts that include the transient presentation. So, master diagnostic algorithm for transient vestibular symptoms is patient with transient vestibular symptom. One dichotomy is, are symptoms ongoing at the time of examination? If the answer is yes, nystagmus, spontaneous or gaze evoke. If it is present, then do a hints plus examination with hearing test, MRI diffusion weighted if the central pattern is seen on the hints examination. If the nystagmus is absent but the symptoms are ongoing, then look the non-vestibular cardiac or metabolic causes, and then in that case, if no vestibular findings emerge, shift towards the non-neurological causes. Look for the cardiac causes by ECG, Holter monitoring, blood pressure in lying and standing position, blood workup, especially glucose, electrolyte, and counts. If the symptoms are not ongoing at the time of examination, they have resolved. That is the patient who says that, doctor, I was dizzy this morning, but at present I am fine. Then you need to do positional test in all patients. That is the Dix Halbach and supine roll test. You should be able to do it with perfection. So apply standing with or without Sudbury or tries scores, not the hands plus. Immediate and sustained response to the liberatory maneuver supports BPPV over vestibular migraine or central positional nystagmus. And if you don't find any positional nystagmus and you don't find anything on the standing protocol, then again you need to look for the non-neurological causes with the ECG, Holter monitoring, orthostatic hypotension, blood workup including glucose, electrolytes, and counts. So it is important to note that all positional nystagmus is not BPPV. The positional nystagmus can also occur in central positional vertigo and vestibular migraine. The characteristics of the nystagmus intensity in BPPV is a strong torsional horizontal. In central positional vertigo is variable. It may be pure vertigo or pure torsional. In vestibular migraine, it is typically low amplitude, low frequency, and low SPV. The latency and fatigue of the nystagmus in BPPV is brief and fatigues on repetition. That is called the BPPV fatigue. In central positional vertigo, there is hardly any latency of the nystagmus. It is immediate and it is non-fatiguing. And likewise in the vestibular migraine, it is persistent and not fatiguing. Response to liberatory maneuver is immediate and sustained in BPPV. There is no sustained response to repositioning maneuver in central positional vertigo and vestibular migraine. The other clues to the etiology is in BPPV, the positional nystagmus matches the plane of the stimulated canal as per the Evol's first law. In central positional vertigo, the apogeotropic horizontal positional vertigo is often observed during the supine roll test, but here there is a rider that this nystagmus does not respond to the maneuvers like Zuma, which are carried out for the cupulolysis of the horizontal semicircular canal. The direction may not match the canal plane, and the positional vomiting is often present in central positional vertigo. In vestibular migraine, there is history of migraine headaches of the other type, like the common and classic migraine. Photo and sonophobia is present. It may mimic lateral canal BPPV pattern, especially in cases of the persistent geotropic horizontal positional nystagmus during the supine roll test, which is the light cupola syndrome, is common in patients with migraine of all types, including the vestibular migraine. So, vertebrobasilar TIA, which is the most important diagnosis to exclude, the diagnostic criteria for probable transient vascular vertigo, brief symptom duration, usually minutes, sometimes up to few hours. Focal neurological signs may be subtle or non-localizing, like dysarthria. Absence of MRI diffusion weighted imaging positive lesions may be present. Increased vascular risk factors, that is the ABCD2 score of 4 or more, and the presence of untreated atrial fibrillation, significant more than 50% narrowing of the vertebrobasilar artery. The scale of problem is very high. Around 15% of posterior circulation TIA present with isolated dizziness, about 10,000 US patients per year. Transient vestibular symptoms preceded posterior circulation stroke in 12 to 21.5% of the cases within prior 90 days. Secondary prevention reduced the recurrent events by more than 93% in confirmed vertebrobasilar TIA patient. That is, the number needed to treat is equivalent to 1. The clinical pearl is that the misdiagnosis rate for cerebrovascular events rises to 24 to 60% when presenting complaints are mild, non-specific or transient. Vertigo triggered by head position changes is actually associated with lower risk than the spontaneous transient vestibular symptoms, but the central position vertigo still accounts for 11 to 20, 12% of the positional cases. So don't over rely on the brain imaging for the acute setting. This is a very important takeaway from this talk. MRI diffusion weighted in up to 50% of the patients is falsely negative for small brainstem strokes, especially when imaged early within the first 24 to 48 hours. CT angiography sensitivity is 14.3 to detect acute vertebrobasilar ischemia. Non-contrast CT has a sensitivity of 21.4% to detect the acute vertebrobasilar ischemia. Practical guide preferred is MRI with diffusion weighted imaging, but a negative scan does not exclude a small vertebrobasilar stroke or TIA. CT or CT angiography is reasonable when hyperacute treatment decision for thrombolysis or mechanical thrombectomy are on table, or to detect the basilar stenosis, dissection or occlusion, not as a rule out tool. MRI perfusion weighted imaging showing cerebellar hypoperfusion without a DWI lesion may be useful biomarker of a central ischemic transient vestibular symptom, but it is not widely available. The bottom line is that clinical bedside testing and structured history remains central. Imaging supplements but cannot replace the clinical examination. Vestibular migraine can look like just vertebrobasilar TIA. The older age, vascular risk factors, focal neurological signs, no personal history of migraine, negative MRI diffusion weighted does not exclude it, and significant vertebrobasilar artery stenosis on angiography. It is a pointer towards the vertebrobasilar TIA. While in the vestibular migraine, younger age, female dominance, personal history of migraine headaches of the other type like the cross chronic common and classic migraine, accompanying migrainous features like photophobia, sonophobia, osmophobia, headache, lack of vascular risk factors, positional nystagmus is low amplitude, low SPV, persistent non-fatiguing like BPPV. So the diagnosis of vestibular migraine requires 5 or more episodes to confirm as per the ICPD criteria. A first episode can only ever be provisional because biomarkers are lacking for the vestibular migraine. The presentation can be hyperacute and disabling. Patients with vestibular migraine occasionally receive thrombolysis before the diagnosis is clarified in future attacks. This is considered safe with the symptomatic hemorrhage is only 0.5% of the stroke mimic cases. So the peripheral vestibular and non-vestibular causes of TVS, the peripheral vestibular are BPPV, the most common, around 0.6% every year incidence. Meniere's disease causes transient audiovestibular symptoms. Vestibular paroxysmia attacks are brief, lasting seconds to 5 minutes, and there are multiple episodes, 30 to 40 episodes per day typically. Cardiovasculars include the cardiac arrhythmias, orthostatic hypotension, postural orthostatic tachycardia syndrome, vasovagal syncope, and carotid sinus hypersensitivity. The metabolic causes and toxic causes are also important. Hypoglycemia, electrolyte disturbances like hyponatremia, hypomagnesemia, alcoholic or drug intoxication, particularly the anti-seizure medications like diphenylhydrin and sodium. We commonly see patients who have been having head injury and were given phenytoin sodium as a loading infusion dose, and they come to the neurologist with acute vestibular syndrome, and you can see the bidirectional gaze evoked nystagmus on extraocular motor testing. Carbon monoxide poisoning is still a important cause in patients who are in rural India where there's too much cold weather during the winters. The other central causes are epileptic vertigo, usually of less than 30 seconds duration, However, the epileptic vertigo is rarely associated. Other seizure types are usually present in such patients. Episodic ataxias and early spinocerebellar ataxia 27B is a emerging entity which is very responsible to the 3 amino pyridine. Vertebro artery compression syndrome, that is the Bow-Hunter syndrome or the rotational vertebral artery compression syndrome, is another classical case of this transient vestibular syndrome. In US FD sample, the general medical diagnosis 49.2 were actually more common than the otovestibular diagnosis, which was 32.9 among the acutely dizzy patients. Don't anchor on the vestibular system alone. That is a very key message from this article. So the recommended workup at a glance adapted from the table 2 is bedside examination for the transient already resolved focal neurological examination plus subtle oculomotor examination, triggered nystagmus like head shaking nystagmus, vibration induced nystagmus, hyperventilation induced nystagmus, and positional tests including the Dix-Hallpike and supine rolled. For the acute ongoing, you require a focal neurological examination plus subtle oculomotor examination, stance and gait examination. The algorithm for the transient already resolved syndrome is standing with or without Sudbury or Triage scores, but Hints plus does not apply here. For acute ongoing, algorithm is Hints plus only if the spontaneous or gaze evoked nystagmus is present. Standing may be applied with or without Sudbury or the Triage scores. Imaging, diffusion weighted imaging if central vertigo is suspected. In any case, in the acute ongoing, the CT and CT angiography if urgent treatment decision like thrombolysis or thrombectomy has to be taken. The other tests include the ECG, Holter, orthostatic hypotension measurement, hearing test, and blood workup for the transient already resolved syndrome. The hearing test, diffusion weighted imaging, MRI, no provocation maneuvers while symptoms are ongoing in acute ongoing patients. So, managing transient vestibular symptoms, the key takeaways are number one, structured history taking, that is, timing plus triggers, drives the selection before any bedside examination begins. Hints plus is only valid for ongoing symptoms with visible nystagmus. Never apply it once the symptoms have resolved and there is no nystagmus. Standing protocol with or without Sudbury or Triage plus scores is the versatile evidence-based choice for resolved or positional transient vestibular symptoms. Positional testing, Dix-Hallpike and supine role belongs in every TVS workup, even without a reported trigger. Vertebrobasilar TIA and vestibular migraine are the key mimics to distinguish. Imaging alone will not settle it. A negative MRI diffusion weighted imaging does not exclude stroke. False negatives reach 50% for small brainstem infarcts. So, my last slide is what the Italians use. The Italian Journal of Emergency Medicine published this a couple of years ago. They look for patients with acute vertigo and unsteadiness with a Frenzel glasses and see if the nystagmus is present or not. If the nystagmus is present and is spontaneous, pluridirectional or vertical, it is a central vertigo. If it is unidirectional, they do a head impulse test. If it is negative, it is a central vertigo. If it is positive, it is acute unilateral vestibulopathy. But if the patient is unable to walk unsupported, it is central vertigo. If the nystagmus is not present, but the patient is unable to walk unsupported, this is a central vertigo. If there is a positional nystagmus, they do a supine roll test and Dix-Hallpike test. It is BPPV. If the patient is unable to walk without support, it is likely to be the central positional vertigo occurring because of a lesion, either demyelination or ischemic stroke in the velocity storage apparatus of the cerebellum, that is the nodulus and uvula. So I finish my presentation here. Hopefully, this will be very important in evaluating patients who have transient vestibular symptoms which are still ongoing or they have passed off. Thank you very much.